네, 안녕하십니까.
Hello, my name is Kim Ki-song from Namsan Dental Clinic. Today, I would like to introduce you to the implant systems as part of our master course. OSSTEM offers a wide range of implants. There were 4 existing main implant systems, each with a different name. TS, the most frequently used one, SS, US and MS. Recently, KS implant was introduced, which stands for Key Solution. This has strengthened connection and is receiving a lot of attention. When categorizing implant systems, there are 2 body type implant, where the implant and abutment are separate, and 1 body type implant such as MS implant, which is used for when vertical or horizontal space is limited, especially in the lower anterior region. Among narrow implants, some are for overdenture and some for provisional uses, but personally I don't think there are many cases to use them. Now, let's classify implant systems by connection. Here are TS, KS with the same appearance as TS, SS, and US. As you know, there are 2 types, internal type where the abutment is connected inside and external type, or Bronnemark type, where the connection is done outside. These days, we mostly use internal types, and among them, this 11-degree tapered TS implants are most frequently used. KS implant, which has recently been released, has a 15-degree tapered structure, and then there is SS implant, which stems from Straumann implant. It has an 8-degree Morse tapered internal connection. Internal connection types can also be classified by tapered angle and indexing, which has to do with implant placement and positioning. Hexagonal shape for TS and KS and octagonal shape for SS. US is an external type but has the hexagonal shape. They can vary depending on the manufacturer, but we can divide implant systems by angle, like this. Let's take an overview of different implant systems. This is a TS implant system which is used most widely. It has an 11-degree tapered structure and it has about 1.2 millimeters of surface with the shape of a hexagon below. The hexagon is 2.5 millimeters in diameter. In regular connection, it is 2.5 millimeters. This is an occlusal view of the actual implant. It is popular in the market as it has a stable connection, as you can see here, and it is easy to deliver prostheses. Depending on the axis of macro design, or the tapered angle, they can be divided into type 2, 3 and 4. The most frequently used one is TS3, with the tapered angle of 1.5 degrees. There's also TS4 of the tapered angle of 6 degrees used for sinus cases or areas with poor bone quality to secure initial stability. TS4 is excellent for securing initial stability, but the surface area is reduced. Hence, TS3 is recommended for general cases. TS system is a submerged type, but usually surgery is done at one stage. It has an internal hexagon shape with a taper angle of 11 degrees. Biggest advantage of using this is that there's less bone loss. This is popular as it has less microgap or leakage and less micromobility, thereby resulting in less bone loss. In particular, for maxillary anterior region, aesthetic quality is important. And given the possibility of various abutment forms and less bone resorption, I can say that my best choice for the anterior region is TS implant. KS implant with an appearance similar to TS was released about 3 years ago with the reinforced connection. Not many know about KS implants, so I'd like to provide an explanation. The tapered angle is 15 degrees. If you look at advantages, various factors have been considered and it has much stronger connection compared with TS implant. You can think of this as an upgraded version of TS. It looks very similar to TS. Actually, both have the same macro thread design, almost same in specifications of length and diameter. Therefore, you can use the same surgical kits to place a KS implant. The only difference is in internal connection structure. The angle is changed to 15 degrees and connection has become deeper. At the same time, the diameter of this hexagon has become a bit shorter. Anyway, in summary, we can say that KS has the same appearance as TS, but its internal connection has become shorter and deeper, increasing the thickness of other parts, thereby improving the strength. Here you can see the difference between TS and KS. Difference in the tapered angle, 11 and 15 degrees. And the size of the hexagon has been decreased. The biggest difference is that while the length and width of the screw are reduced, thickness of other parts such as the implant and abutment has increased, leading to stronger connection. Strength has increased by a whopping of about 4 times. Simply put, you can see around this area that KS implant has a thicker titanium outer wall. Various implants continue to show excellent results. But when placing 4.0 implant, I always choose KS because connection has been strengthened about 4 times compared with TS. And there is no difference in implant placement process. Components only have changed, so you have to have more of them in store at a clinic. But still there are many more benefits to using this system. That is why more and more people are now choosing KS. The thread is the same as you can see here. The only difference is the internal connection. It has become narrower and deeper. Among many other advantages, the biggest advantage is related to implant fracture possibility. It can prevent implant fracture and screw loosening has been reduced. The amount of settling down has been reduced as well, so there is less screw loosening. The area connected to a prosthesis is similar to TS, so you cannot really tell the difference. One advantage in using KS is that it has unique abutment holding system like this, allowing for single-handed use. You can push the abutment with one hand and deal with the prosthesis with another. This is a big benefit. Next is SS implant. Personally, I have mixed feelings about it. I used to use it very frequently, but as I started to use one-guide surgery, I came to use it less. But I still believe that SS implant has the strongest connection. The problem is that it has machined surface in the neck area. So it's unfavorable to use in areas where aesthetic quality is important, and it's quite inconvenient compared with TS in terms of handling prosthetic components. It has internal octagonal shape. And there are 2 options for gingival thickness, 1.8 and 2.8 millimeters. Platform diameters are 4.8 and 6.0 millimeters. This wide type with the diameter of 6.0 is mostly used for posterior teeth, and for other regions, regular platform with the diameter of 4.8 is used. Implant diameters range from 3.5 to 7.0 millimeters. And the macro design is the same as TS. The only difference is the neck area. Because of the neck, it is called gingival level implant or tissue level implant. As in TS, there are both straight and tapered types, but only to type 3, not 4. With a tapered angle of 1.5 degrees, it has the same appearance as TS3. Like I mentioned earlier, the machined surface area will be positioned at gingiva level. That is the basic protocol. If possible, it can go a bit more deeper, and for the abutment, CAD/CAM or COM-OTTA Plus can be used. Unlike other implants, the SS implant has the bevel area of 0.65 millimeters, which will be in direct contact with the prosthesis. So, there is no sinking down and connection is also enhanced. However, if you place this implant deeper, you no longer can use the bevel as the margin of the prosthesis. There are two options for gingival cuff height, 1.8 and 2.8 millimeters. So, depending on gingival thickness, you can choose an appropriate one. Despite all these benefits, when you place SS implant for a thick gingiva at the bone level, using the bevel as a margin for the prosthesis is no longer available. In that case, you can use COMOCTA plus abutment, which raises up the margin from implant level to abutment level. This abutment with the gingival cuff, looking as if a cement-type abutment, can be used to change the margin position to load the prosthesis. I personally believe this is the most suitable choice for now, because I usually use the ER type, which requires retrievability. If implant bevel is used like this, there will be a problem with the cement. Thus, I use COMOCTA plus or one-fit abutment for SS. The advantage for SS is that it has this part that goes through the gingiva, thus non-submerged type. It also has an octagonal shape. That's the advantage, too. More than anything else, this structural stability is outstanding more than any other implant systems. Next is US implant. This is an external implant and has been used from the early days of implant, from 1965. And this is the most basic implant type. But nowadays, US system is used only for about 10% of all implant cases, and the rate is going down over time. But we can say that it is no longer popular in the market and thus it is being used less frequently. For multiple use cases, it can bring about very good results. But when you have to connect the healing abutment after surgery, this has some disadvantages compared to an internal type such as TS. That is why, I think, more and more people are turning to use other implants than US system. Various external heights are available, but the standard is 0.7 millimeters with the hexagonal shape. As there are many other implants using the same connection, it is a good option in terms of compatibility. That is why it is called a US, universal system. In the past, I used this type of implant quite a lot. Now, with 2 decades past, I still believe that it was a decent connection from various perspectives. But the current trend is to place the implant more deep, considering the simplicity of surgery and aesthetics. Hence it is used less often. As for the joint, it has a butt joint structure. The implant and the abutment will be in contact with each other surface to surface. So abutment sink down rarely occurs, unlike in internal connection implants such as TS. We tend to think that there will be much more cases of screw loosening in external implants compared to internal types. But it wasn't like that according to my clinical experience. In that sense, it is not bad. But, I need to point out that in the case of connection with the healing abutment, there can be bone interference here, leading to a little bit of inconvenience. It comes in various hexagonal sizes. OSSTEM offers 4 options: mini, regular, wide and wide PS. PS stands for platform switching. Wide implant with a hexagonal size of 2.7 millimeters is called PS. This is an implant system for platform switching. US implant is an external type as the connection part is projected to the outside. And it has butt joint structure where surface and surface will be in contact. And here it is written in green color. For multiple cases with a screw type, especially, I believe that this external type will lead to good prognosis. In the case of using screw type for multiple teeth or in the case of ER type, I believe it has its benefits. But it is true that currently, this type is being used less and less frequently, eclipsed by the popularity of internal type implants. In the mandibular anterior region, we have limitations in terms of mesiodistal and buccolingual dimension. Thus, it is quite difficult to use two-piece type implant where implant and abutment are separated due to the lack of bone mass. To address this issue, OSSTEM has manufactured a one-body MS implant. But it is true that as the MS implant is placed with just once or twice of drillings, you can have some difficulties securing initial stability, and the failure rate is also higher than other areas. But personally, I prefer to use MS implant on mandibular 4 incisors. And if you master basic technique, you can get great clinical results. So for lower anterior region, I strongly recommend MS implant. There is no abutment screw and, as shown here, this is a one-body implant where the implant thread and abutment are combined into one. Because it is very thin, it is made of alloy. This is the only implant made of grade 5 titanium, and as for the surface, SA surface is mostly used, but I personally prefer RBM. Preference can differ from person to person. There are 3 options in the MS implant system: MS narrow ridge for mandibular teeth, MS denture for overdenture cases, and MS provisional used while we wait for osseointegration when multiple implants are placed. I hardly use these 2, and I've never used this one. Please take note that implant and attachment are connected. Thus, there is no problem in using this as a provisional, but you have to consider that you cannot replace the attachment after it is worn out, if you are going to use this as a final one. I would like to point that out again. I actually used quite a lot of MS implants for the mandibular anterior region. In terms of the results, the success rate is very high. But, if an error happens with once or twice of drillings, you cannot secure initial stability. In that case, this will end up in failure. So, if you want to place MS implant properly, you can use one MS kit, an option of one guide for easier and more precise positioning of the implant. MS implant has concave gingival cuff area. There are 2 options, 2.5 and 4.0. As for a young patient with a congenitally missing tooth in the anterior region, you will have to use 2.5 millimeters. But for elderly patients, I primarily use gingival cuff of 4.0 millimeters and choose the right implant. Implant diameters range from 2.0 to 3.0. I personally prefer an implant with the diameter of 2.5 and the length of 13 millimeters. This is what I use most frequently. By the way, I wonder whether we really need this 3 millimeter wide one. For length, the range is from 8.5 to 13 millimeters. My personal preference is 13 millimeters. As for denture type, this is a ball attachment for overdenture. But if there is wear and tear on the attachment after osseointegration, there can be issues, so we have to keep this in mind. And in the case of placement of multiple implants, you can use this provisional implant to help restore masticatory force while the osseointegration is underway. But as the osseointegration can be completed quite quickly, and with just 3 or 4 implants placed we can go ahead with the provisional prostheses right away, I rarely use it. MS implant body is inclined by 5 degrees as you can see here. So when MS implants are used as a bridge on the mandibular anterior region and 2 are connected, then it will result in the inclination of about 10 degrees. With 10 degrees apart, there will be no limitations in using prostheses. But above 10 degrees, you will have to go with abutment reduction. Thus, through a surgery guide, you have to make sure 2 implants are placed in parallel in the bridge case. For this implant, you cannot choose ER type, leaving you with the only option of using a cement-type prosthesis. And due to the limitation in dimension, I don't think zirconia is appropriate for the material. It can be too big to fit. So, I personally use PFM prostheses for MS implant. Today I have briefly introduced different implant systems. If you're interested in more details, please come to the offline master course planned for February next year to get more in-depth knowledge. I hope to see you there. You'll be able to get significant knowledge and information as to how to use different implants. Then, you'll be able to choose the right implant system which lasts longer. This brings me to the end. I am looking forward to seeing you in person at offline course. Thank you.